Pharmacology is interesting, but it's perplexing when it comes to remembering. Let's have a quick revision. Parkinson's disease is a progressive degeneration of dopaminergic neurons located in the midbrain of the brain negros striatal, which leads to involuntary motor movements. The main signs and symptoms include resting tremors. Rigidity is of two types, that is cogwheel in the upper limbs and lead pipe rigidity in the hind limbs. Akinesia or bradykinesia, no movements or slow movements respectively. Called mask face, and the patient also experiences postural instability such as stooped posture. Before proceeding into the treatment, let us firstly understand in brief how what is actually being affected in the disease. Basal ganglia is the structure which dominantly controls movements. It uses both excitatory as well as inhibitory interneurons to connect those structures. Glutamate excitatory interneurons. GABA inhibitory interneurons. Basal ganglia have two pathways. The direct pathway, which initiates movement, and the indirect pathway, which terminates movement. In the direct pathway, the motor cortex sends excitatory signals, donated by the orange-colored arrows, to striatum. If you remember, striatum includes putamen and caudate nucleus. This excitatory neurons are glutamate. Next, the striatum sends GABA interneurons to globus pallidus internus and the substantia nigra. Inhibitory signals are depicted as blue arrows. They both send the inhibitory signals to the thalamus. And you see the arrow. It thereby sends the excitatory signal back to the motor cortex. And the loop continues. The net effect is, it turns on the motor cortex and disinhibits the thalamic control of motor planning. Alright. So in order for the brain to do this, thalamus, which is integration center of the brain, has and yielding motor output through this loop. That is a direct pathway, which initiates movement. The indirect pathway also starts with sending excitatory signals from motor cortex to striatum. So this is where the indirect pathway differs. That the striatum bends inhibitory interneurons to the globus pallidus externus. So you can see in the flowchart, the globus pallidus externus will send inhibitory neurons to the subthalamic nucleus, and this will send excitatory interneurons back to the globus pallidus internus and substantia nigra, and this way indirect pathway take turn out and comes back and finishes exact same way as direct pathway, which is same way as direct pathway, which is to say that globus pallidus internus and substantia nigra send inhibitory signals to thalamus. And you see that the thalamus sends excitatory signals to the motor cortex. The acetylcholine neurons opposes the activity of dopamine. Let's just assume for some reason dopaminergic neurons got damaged. D1 receptor goes for direct pathway, whose imbalances causes akinesia or bradykinesia and resisting of movement. D2 receptor goes for indirect pathway. Imbalance of acetylcholine causes tremors and rigidity. The pharmacology involved in this disease is either it should be an increase in dopamine or it should be decrease in acetylcholine. There is an inverse relationship between acetylcholine and dopamine. There are 5 classes of drugs involved. Dopa-decarboxy inhibitor, levodopa and carbidopa are given in combination. Monoamine oxidase inhibitor, COMT inhibitor. Carbidopamine
works
by inhibiting the dopa decarboxylase. And the goal is to increase the precursor levodopa. Because we are preventing it from being peripherally shunted to dopamine. Since levodopa will be increased, hence it can pass through the blood-brain barrier and convert itself into dopamine within the brain. As you can see, how this enzyme converts dopamine into dopac, leading to lowering dopamine levels. Hence we use MALB inhibitors, that is selegiline and resagiline. COMT converts dopamine into 3-MT, which is inhibited by the medications tolcapone and entacapone. Tolcapone has higher efficacy than entacapone, and it is likely to cause hepatotoxicity. Increase in the dopamine in the synaptic cleft, and those drugs would bind to synaptic dopamine receptors, stimulate postsynaptic receptors, and functionally increases the level of dopamine in the substantia nigra. They inhibit the reuptake in the presynaptic neuron and maintains the level of dopamine. And for that, amantide works. It is also known as antiviral.